Hello everyone. Today we will discuss some of the cardiac diseases. To start with an overview of heart diseases, there is heart failure, whether left-sided or right-sided. There is ischemic heart disease, whether angina pectoris and the myocardial infarction. And we will discuss the first two subtypes during this lecture. Hypertensive heart disease and cardiomyopathies and myocarditis also are of the heart diseases. We will discuss them next lecture. And we have congenital heart diseases, valvular heart diseases, pericardial diseases, and cardiac tumors, which are rare conditions. So we will start with heart failure. We call it also congestive heart failure when it involves both the right side and the left side of the heart. It's a common endpoint for many cardiac conditions. It's progressive with poor prognosis. And the idea in heart failure is that the heart cannot generate sufficient output of blood to meet the metabolic demands of the tissues. So the tissues will suffer from poor perfusion and hypoxia. It can occur as a consequence of a greatly increased tissue demands. It's not necessarily the problem always in the heart. Sometimes there is a problem with increased tissue demands, like in the cases of anemia due to the hypoxia and the diminished oxygen carrying capacity of the blood. So the tissues will need more oxygen and the heart will need to pump at a faster rate with the marked tachycardia ending with heart failure. The other condition is hyperthyroidism, in which the same idea of the tachycardia and increased heart rate, which will end with heart failure because of the increased workload on the heart to meet the tissue demands. Heart failure can be divided into acute and chronic. Acute, in which there is an abrupt onset, sudden onset of symptoms, usually as a result of large myocardial infarction or valvular dysfunction, like the mitral valve regurgitation, for example, or aortic valve problems. Chronic heart failure has the same symptoms and signs of acute, but they occur gradually and insidiously over a long period of time, so they will be less severe. The other classification is that the heart failure can be classified into systolic dysfunction or diastolic dysfunction. Um, Systolic dysfunction in which there is a contractile dysfunction. So the problem is in the contractility um, of the heart, like what occurs in ischemic heart disease and in the cases of hypertension, in which the patients develop hypertrophy of the heart. So there is systolic dysfunction. Or it's a diastolic dysfunction in which there is a problem in the during the diastole, the period in which the heart is filled with blood. So it's a filling dysfunction, as what occurs in left ventricular hypertrophy, which can occur also as a consequence to hypertension, but it can this hypertrophy will lead to enlarged size of the heart, so the blood supply will not be sufficient with time, so they will develop also a systolic dysfunction. Also, fibrosis of the heart wall can lead to diastolic dysfunction. Also, heart failure can be divided according to the side that is affected, and when this can be classified into left-sided heart failure and right-sided heart failure. The causes of left-sided heart failure, in which, as you know, the left side of the heart is composed of the left atrium, which pumps blood to the left ventricle through the mitral valve. Then the left ventricle pumps blood to the rest of the body through the aortic valve. So, ischemic heart diseases are one of the most common causes of left-sided heart failure. Systemic hypertension, because it leads to, as we said, to cardiac hypertrophy, mitral or aortic valve diseases, whether stenosis or regurgitation, also primary diseases of the myocardium, like amyloidosis, for example, or myocarditis, etc. The morphologic and clinical features of left-sided heart failure all stem from the decreased cardiac output, وبالتالي decreased perfusion to the tissues. Also, this will lead to elevated back pressure in the pulmonary circulation because the, um, the heart has a problem in the pumping to the peripheral tissues. So, blood will pool in the heart and the venous return from the lungs will decrease. So, the blood will pool in the lungs, leading to congestion in the lungs. So all of the or most of the clinical manifestations of left-sided heart failure are due to the lung congestion and the decreased perfusion to the peripheral tissues like the kidney, the brain, the tissues, the skin, for example, etc. The morphology of left-sided heart failure mainly affects the heart and the lungs. And the heart changes depends on the underlying cause of the uh, heart failure, whether it is an ischemia, myocardial infarction, left ventricular hypertrophy, as in hypertension. All of these also can be present at the same time if the patient is hypertensive with an ischemic heart disease. In cases of hypertrophy, there will be myocyte hypertrophy and interstitial fibrosis. We might see features or signs or an evidence of a recent myocardial infarction or an old myocardial infarction with a site of scarring or fibrosis. By the way, usually these changes are seen upon autopsy studies of the heart. On X-ray or on imaging studies, we might find the cardiac hypertrophy or enlargement of the size of the heart. The lungs, the changes in the lungs depends on whether it is an acute or chronic left heart failure. In acute left heart failure, there will be congestion, there will be edema in the lungs, accumulation of interstitial fluid, plus minus pleural effusion, accumulation of fluid in the pleural cavity. The lungs will be heavy, large, and boggy. There will be interstitial transudates, as we said, leading to edema, and edema fluid also can collect in the alveolar spaces. This is what we call acute pulmonary edema. In the chronic left heart failure, the changes might be less severe in regarding to the presence of edema fluid. However, the congestion will lead to red blood cell extravasation from the leaky capillaries اللي موجودين في اللungs to the alveolar spaces. These red blood cells are engulfed by the alveolar macrophages. These alveolar macrophages will turn into the brown color because they will be henocidrin laden and we call them heart failure cells. We might see these cells on bronchoalveolar lavage specimens for the patient, for example. The clinical features, most of them, as I said, they stem from the pulmonary congestion and edema. So first, dyspnea, which is shortness of breath on exertion. It's the earliest and most significant symptom of left heart failure. Cough also can be present due to the fluid transudation and due to the pulmonary edema and the air spaces. Sometimes the cough is productive of a frothy sputum. Orthopnea, which means dyspnea upon lying down when in the recumbent position, because the venous return to the heart will increase and the blood flow to the lungs will increase, so the congestion will increase. This orthopnea is relieved by sitting or standing. لذلك دائما نلاحظ إنه مرضى ال left sided heart failure بيناموا in a sitting or a semi-sitting position. The paroxysmal nocturnal dyspnea also is a feature in which there is extreme shortness of breath, like a feeling of suffocation that awaken the patient from sleep. يعني بيصحى مختنق. Um, Cardiomegaly, because also we said that the The heart can be hypertrophied, um, and tachycardia. The heart will need to pump faster to meet the demands of the tissues, so the patient will have tachycardia. fine rails at the lung bases وهذا بيسمعه الطبيب بالستethoscope سماعة الطبيب due to the crepitations of the edema fluid that is present in the alveolar spaces. Also, these patients may develop atrial fibrillation due to the left atrial dilatation اللي بيصير نتيجة الهارت failure. Um, and due to the um, enlargement and the dilatation of the left atrium. So the patients are prone to this type of arrhythmia, atrial fibrillation, which can be fatal and can cause sometimes sudden death. Diminished cardiac output also is an important feature. Like these patients may develop azotemia or renal failure, pre-renal renal failure due to the decreased blood flow to the kidney. Decreased blood flow to the brain will result in hypoxic encephalopathy, and decreased blood flow to the tissues also will lead to cyanosis. Right-sided heart failure, it's most of the time it's a consequence of left-sided heart failure. So the patient will have left side heart failure with time, and due to the pulmonary congestion and the pulmonary engorgement with the blood, the right side of the heart also will fail because of the increased pressure in the pulmonary circulation, and this will make a burden on the right side of the heart, leading to right-sided heart failure. Sometimes it can be an isolated right-sided heart failure, like what we call cor pulmonale. So cor pulmonale is a right-sided heart failure due to any disorder affecting the lungs. Parenchymal lung diseases, fibrosis of the lung, primary pulmonary hypertension, the recurrent pulmonary thromboembolism, etc. So any disease that affects the lungs primarily can lead with time to right-sided heart failure, and we call it cor pulmonale. Right-sided valve disorders also, like the tricuspid valve and the pulmonary valve diseases, can lead to isolated right-sided heart failure. The morphology stems from the engorgement of the systemic circulation and the portal venous systems with blood. It's so pronounced, and the pulmonary congestion here is minimal, especially if it is an isolated right-sided heart failure. The changes will be in the liver and the portal system, in which the liver is enlarged. We call it congestive hepatomegaly due to the congestion and pooling of the blood and dilatation of the sinusoids of the liver. We call it in this instance nutmeg liver. With prolonged congestion and fibrosis, cardiac cirrhosis may develop. تجمع الكبد بسبب القلبي, and portal hypertension also due to the engorgement of the portal vein with blood. All of these stem from the decreased venous return to the heart. So the blood will collect in the peripheral venous circulation. So portal hypertension, enlarged spleen, and congestion in the spleen leading to congestive splenomegaly. Also, there will be bowel congestion and bowel edema, and that may affect the absorption of nutrients in the bowel. Also, fluid may collect in the pleural cavity, pericardial cavity, and in the peritoneal cavity, leading to pleural effusion, pericardial effusion, and peritoneal effusion, which we call it ascites. Also, the congestion may occur, and the edema may occur in the subcutaneous tissues, in the skin. We call it pitting edema, like in the feet and in the lower limbs. And if the patient is in a supine position, it will be in the presacral area. The clinical features also stem from the morphologic findings like hepatomegaly, splenomegaly, peripheral edema and congestion, pleural effusion, ascites, and some pericardial effusion, as I said. If the patient is having congestive biventricular heart failure, both right-sided and left-sided failure will issue, and both symptoms will occur in the same patient. The second topic is ischemic heart disease, which is also one of the most important causes for heart failure. Uh, Ischemic heart disease is caused by myocardial ischemia. Myocardial ischemia means there's an imbalance between the cardiac blood supply and the myocardial oxygen and the nutrients demands. So whether there is an increased oxygen demands, um, like when there is a cardiac hypertrophy, for example, or when there is decreased blood supply, like when there is an abnormality or atherosclerosis affecting the coronary arteries, the result will be myocardial ischemia. It's the leading cause of mortality in the United States of America and other developed countries. In more than 90% of cases, it is caused by reduced coronary blood flow secondary to atherosclerosis, which we have discussed in the previous lecture. So دائما ischemic heart disease بيستخدم as a synonym with coronary artery disease because in over 90% of cases it is caused by a disease in the coronary arteries, mainly atherosclerosis, which leads to narrowing of the coronary arteries and decreased blood supply to the heart. Other causes of ischemic heart disease, like increased ischemic demand, like hypertensive cardiac hypertensive hypertrophy of the heart, cardiac hypertrophy, and increased heart rates, for example, in the cases of anemia and hyperthyroidism. So this will increase the cardiac demands and the patient will develop cardiac ischemia. Diminished blood volume also, like in cases of hypertension, shock states, which accompanies some severe hemorrhage or bleeding. Also, it will lead to diminished blood volume and diminished perfusion to tissues, not only the heart, also the kidney and the brain, etc. Diminished oxygenation, like in cases of, for example, pneumonia or congestive heart failure, because there is decreased cardiac output, but this will lead to cardiac ischemia. Also, the diminished oxygen carrying capacity in the blood, like in cases of anemia and carbon monoxide poisoning. These causes they only constitute about 10% of the cases of ischemic heart disease. Again, the most important cause is coronary artery disease. Clinical presentation, there is what is called cardiac syndromes. These cardiac syndromes are divided into four subtypes: the angina pectoris, the myocardial infarction, chronic ischemic heart disease with congestive heart failure, and sudden cardiac death. Angina pectoris means ischemia to the heart leading to pain, but not associated with myocardial cell death. However, myocardial infarction on the other side, it is an ischemia that causes cardiac muscle death. Chronic ischemic heart disease with congestive heart failure, it means there is cardiac decompensation, um, which occurs usually after an acute myocardial infarction or secondary to repetitive many small ischemic insults to the heart. At the end, they will lead to mechanical pump failure and congestive heart failure due to the ischemia. Sudden cardiac death, it's most commonly from a lethal arrhythmia leading to cardiac death. However, less commonly they can be due to an acute myocardial infarction leading to tissue damage in the heart and sudden cardiac death. The acute coronary syndromes هم الانستable angina اللي راح نحكي عنها كمان شوي, which is subtype of angina pectoris, the myocardial infarction, and the sudden cardiac death. Collectively, these three subtypes, we call them acute coronary syndromes. The subtypes of angina include stable angina, first, second, prinzmetal angina, and third, unstable angina. The stable angina, it occurs at certain levels of exertion, so the blood supply to the heart is adequate during rest or with certain exertion. However, above these levels of exertion, the patient will start suffering from symptoms. The prinzmetal angina, it is due to a vascular spasm, coronary artery spasm, and the unstable angina, it means the symptoms they occur progressively with less exertion عن اللي المريض متعود عليه في الستable angina. So a very trivial exercises or daily activities will lead to symptoms, or even they can occur at rest. The pathogenesis of ischemic heart disease, inadequate coronary perfusion relative to the myocardial demands. Most of the time it's due to a fixed atherosclerotic occlusion of the coronary arteries. Sometimes ممكن يكون معاهم superimposed thrombosis أو vasospasm. So again, 90% of cases هم due to the atherosclerotic occlusion of the coronary arteries. This narrowing can affect any of the coronary arteries, whether the main coronary arteries or the branches of the main arteries. In cases of a chronic ischemia, collateral blood vessels can develop, and they can protect the patient against myocardial infarction because if the original vessel, even if the original vessel is completely occluded, because there is a new circulation, new blood vessel that formed due to the chronic ischemia that will supply the heart with blood. That's why sometimes myocardial infarctions in the elderly who has a long history of coronary atherosclerosis and myocardial ischemia and long history of angina pectoris, those will rarely develop myocardial infarction, or if it develops, it will be milder, in a milder form. However, if there is an acute block of the coronary arteries with no previous history of chronic ischemia, there will be no time for these collaterals to develop, and the infarction will be severe and it can cause sudden cardiac death زي اللي بيصير باليونجر patients اللي بيصير في عندهم acute block of the coronary arteries. The obstructions are divided into fixed obstructions of less than 70% by atherosclerosis. So the narrowing is mild, and the patients are usually asymptomatic. However, of the narrowing is more than 70% of the vessel lumen. هاي بنسميها الكريتيكال stenosis. هون البيشنت ببلش يشكي من الستيبل angina اللي هي when هذا blood flow كافي during resting conditions. However, above certain levels of exercise, the patient will develop symptoms because the blood will not be adequate. And fixed stenosis, occluding more than 90%, 90 or more than 90% of the vessel lumen, it will lead to unstable angina. However, if there is a superimposed thrombosis on this occlusion due to an erosion or rupture of the atherosclerotic plaque, this will trigger the acute coronary syndrome like myocardial infarction or sudden cardiac death, or sometimes severe forms of unstable angina. So as you can see here, this is the normal blood vessel in which there is no narrowing at all. Here with atherosclerosis, with fixed coronary obstruction, if it is more than 70% of the lumen is obstructed, so the patient will start to have stable angina. However, if there is a rupture or disruption of the plaque, like ulceration or erosion of the plaque, this will lead to superimposed thrombosis that starts with platelet aggregation. That's why we gave these patients aspirin in cases we think there is a myocardial infarction or a threatening myocardial infarction to inhibit this platelet aggregation step and inhibit the thrombus formation, which will lead sometimes to partial occlusion, so the patient will have unstable angina, or complete occlusion of the blood vessel leading to myocardial infarction. So angina pectoris is an intermittent chest pain due to the transient and reversible myocardial ischemia. We said that the occlusion is more than 70% of the vessel lumen. It's divided into typical or stable angina, in which there is an episodic chest pain at certain levels of exertion. The pain is described by the patient as a crushing, squeezing, substernal sensation, heaviness that radiates sometimes to the left arm or to the left jaw, showing some more referred pain. This pain is relieved by rest or by drugs such as nitroglycerin, which is given in sublingual pattern because it's a vasodilator. It will lead to the vasodilatation of the coronary arteries and relieving of symptoms. The presbyteral angina or variant angina, this type occurs at rest. It's caused by coronary artery spasm. Typically occurs near an existing atherosclerotic plaque. However, it can occur also in a completely normal blood vessel. It responds promptly to the vasodilators such as the nitroglycerin or the calcium channel blockers. The unstable angina or the crescendo angina, it's increasingly frequent pain with minor levels of exertion or even at rest associated with plaque disruption and superimposed thrombus. Most of the time, this thrombus does not occlude the vessel totally, so it will not result in MI, but it will result in an unstable angina. However, it is described دائما as a harbinger of a myocardial infarction. يعني اللي بيصير عنده unstable angina, it should be treated, he should be treated as an MI because at any point or at any time he might develop MI due to complete vascular occlusion. Sometimes the cause is due to the embolization of a thrombus, sometimes is due to a vasospasm. And thank you.